All of you, please mute yourself. Let's talk about a new topic, but it is a very related topic uh, from the management of labor. That is called partogram. Partogram is a graphical representation of the event what happens during the labor, or what we are going to do, how we are going to monitor labor. Okay, so everything is recorded as a graph or as a graphical representation, and that is known as partogram. Now uh, all of you, I'm not sure whether you can see it or not, but don't worry. In the coming slides, so many times we'll talk about this graph. Okay, this whole class is about this graph only. Now see here, there is a name of the patient. Okay, this is the gravida and para hospital number, which is given to every patient who are admitted to the hospital, date of admission, time of admission, ruptured membrane when and how many hours before. So these are the important information which is written here after taking the good history. This is the fetal monitoring. This is the fetal heart rate. So we examine the fetal heart rate and we enter it here, and there will be a graph which is formed. If it is crossing more than 180 or coming below than 100 per minute, it is abnormal. We all know that. Okay, this is definitely abnormal. After this, there is a liquor. Liquor means amniotic fluid. Okay, what is the color of the liquor? All those things we have mentioned here. And molding of the baby. Now molding means, what is molding? Let me ask that question first. What do you mean by molding? Yes.
During the labor, so the compression of the skull bones of the fetus.
So it is immature fusing of this sort of the sutures of the skull bone.
Okay, good. Abbas and Uzair, they are answering it quite well. So molding means, remember, the overlapping of the skull bone during the process of labor is called molding. They overlap with each other. Okay, that's why, that's how the diameter of the presenting part will become slightly smaller, and it may fit into the birth canal so that it can come out. This is called molding. We need to judge that. But one point is very important here. If there is excessive molding, okay, excessive molding, but there is no descent of the fetal head, that means the pelvic cavity is not enough or not adequate in diameter. This is known as cephalopelvic disproportion. It is always important one. Another important phase is, what is the dilation of the cervix? What is the descent of the fetal head? That was I was talking right now. Okay, this is the latent phase of the labor. This is the active phase of the labor. And there are two lines, alert line and action line. We'll talk about this a bit later. Alert means during this time we should be cautious, we should be alerted. And action, okay, before this action line we should take some action. After the action line is crossed, it's already a bit late. Contraction per 10 minutes is judged here. Okay, how much oxytocin you are giving is written here. What type of drugs we give, how much IV fluid we give to the lady, we write it here. What is the pulse and blood pressure in that lady, we write it here and make a graph. What is the temperature, we record it here. And about the urine, is there any protein present, is there any ketone body or acetone present, and what is the volume of the urine. In one graph, you have recorded so many things. So just looking at this graph, we can exactly know how the progress of the labor is happening. So this is known as partogram. Now, with this information, let's enter into the topic. Now, see this. Let's start with the definition. Partogram is a graphical information about the progress of labor, in which the salient information about the fetal well-being, maternal well-being, and the progress of the labor are recorded into a chart. So with how the baby is doing there, how the mother is doing, and whether the labor is progressing according to the expectation or not. Everything is well known by looking at the chart, partogram. It is required for all ladies who are in labor, either low or high risk group. So this is one of the important part of the monitoring of labor. So as a MBBS student, as a medical student, you must know what is this partogram, how it is maintained, and what information we get from here. Now the same, okay, this is the same slide which I have repeated. See this, the same thing is written here. Okay, so we'll talk about this one after other. Now let's divide this partogram into different sections. So the first on the top is mother information or general information regarding the mother. Now one example is given here. Okay, the name of the mother is written here. She is gravida 3 and para 2. Okay, gravida 3 and para 2, and there is no history of abortions. There is no history of the abortion. Hospital number is written here. This is date of admission. Okay, time of admission, and ruptured membrane, yes. Okay, 1 hour before. So this is very relevant and important information from the mother. This is the fetal heart rate. See this? They have nicely taken the fetal heart rate, and then one graph is made there. So what is the fetal heart rate? We count it and record here. What is the character of the liquor? Is it normal color or not? Normal color means we are fine with that. If it is meconium stained, that means the baby or the fetus is hypoxic inside the uterus. It is already in trouble. So we need to take that baby as quickly as outside. We check for molding also. Excessive molding is also not good. Okay, molding is normal if it is happening as expected one. But if excessive molding, excessive overlap happening, but there is no descent proper, then molding is also not good. It signifies the pelvic cavity is very narrow. The third part of the partogram is to know about the progress of the labor. Now see this. What is the dilation of the cervix? Okay. What is the descent of the fetal head or presenting part? And what is the uterine contraction? So it is all maintained in this part or in this area. What medication that lady is getting? Oxytocin or any other? So we have to mention here. And then what is the vital signs in her? What is the blood pressure, pulse, temperature? Okay, we have to record here. And regarding the urinary finding, if there are any abnormal urinary finding, we have to mention here. So these are the different parts of the partogram. Now let's elaborate on this. This class is all about this elaboration of the partogram. Why is it important to record the progress of the labor? If somebody asks you that question, the answer is very easy. The answer is quite easy. You can answer in this way. Number one, to provide continuity of care, to provide a basis of decision making, to facilitate the research, to allow audit and review, and to defend one's action. If there are no documentation, there is no defense. So let me elaborate quickly on this important point. To provide the continuity of care, definitely, it is the evidence of our care of that pregnant lady, okay, or the lady who has come for the delivery of the baby. It is evidence. Yes, we are checking the fetal heart rate and we are tracing it there. We are checking the vital signs from the mother and we are keeping a report of there. Okay, so this is a evidence of continuity of care. It provides a basis of decision making. Definitely, there are two lines: alert and action. If it is crossing the action line, if the duration is longer than that, then we definitely have to do something. If there is abnormal color of the amniotic fluid, we definitely have to do something. If there is presence of ketone body in the urine, we definitely have to do something. If there is high blood pressure, okay, if there is seizure along with that, we definitely have to do something. So these are the important decision making, and Partogram is helping us to do that. The third point is facilitating the research. Why this documentation is important in the hospital? So many of the medical students, so many of the obstetricians are doing research. Okay, what type of pregnant lady have come there? Is there any problem during the stages and phases of the labor or not? How many of them are having prolonged labor? How many of them are having cephalopelvic disproportion? So this is all about research, and Partogram is helping in that. Another one, to follow the audit and review. Definitely. Okay, every month or every 6 weeks, in each of the department in the hospital, they will conduct review and the auditing. Now, what does that mean? What type of cases they have handled in that duration? How many of those ladies die, for example? How many of the baby die during the delivery? Or how many cases prolonged labor? How many cases of cesarean section? How many cases of vacuum delivery or forceps delivery? So all of these elaboration is called auditing and review. And then to defend one's action, we have to document. Without documentation, you cannot defend yourself. If you say, yes, I was there, I was present there, and I was taking good care of that lady, but who will believe you if you have not documented anything? Okay, so whatever you do, please document it. And this Partogram is excellent way of documenting the thing, what is happening inside the liver. Let's move on. Now, these are the significance of the Partogram. It is a managerial tool which is used to record all observations made on a woman and fetus in labor in one chart. It helps to identify at an early stage those women whose labor is slow or prolonged. And this is a managerial tool for prevention of prolonged labor, definitely. That's why we are tracing it. We're tracing each and every event so that we can act in time, okay, to prevent from the prolonged labor. Now, let's talk about the different types of Partogram here, okay. So these are not a really important part of the lecture. You see this? This is known as Friedman's Partogram, which was developed in 1954. And according to this Friedman's Partogram, there are two phases of the labor based on the dilatation of the cervix. And we still, follow that, isn't it? These two phases of the labor in the first stage of the labor. These are latent phase and the active phase. And that dilatation is either less than 3 centimeter or more than 3 centimeters. Everybody know that. So this is according to the Friedman's Partogram. Another is a Philpott and Castle, which was developed in 1972. And according to this, okay, it has introduced two lines here, the alert line and the action line. Now let me show you where is that alert and action line here. So please pay attention. This is known as alert line, okay? This is the first line, and the second is action line. So alert line, we should be alerted about the progress of the labor. Already, something is happening here, like that. Action, definite action is needed. So alert line represents the mean rate of slowest progress of the labor, and action line, appropriate action should be taken. Still, if you do not take the action, then some problem can happen to the baby or the mother also. Normal labor is plotted to the left of the alert line. So in this area, the normal labor occurs here in this area. This is the meaning. So it's the latent phase, okay, and the active phase. Latent phase and the active phase. If somebody asks you, what is the boundary of latent phase and active phase? What is the quick answer? What is the boundary? After what diameter we call it active phase?
The latent phase up to 4 centimeter dilation of cervix, and selective up to that ultimate 9 to 10 centimeter mainly.
Exactly. Very easy question, okay? Don't get confused. This is the easiest question you can get at this moment. Latent phase, up to 3 centimeters cervical dilation. After 3, okay, or in some of the book it is mentioned 3 to 4 centimeter, no problem. The active phase starts and it lasts up to 10 centimeters. Okay, see this. This is the active phase of the labor. Okay, this is the action line. The green one is the alert line. Now we'll divide this partograph into 3 components, the important 3 components. Part 1 is the fetal condition, which is recorded at the top. Part 2 is the progress of the labor at the middle part of the graph, and part 3 is the maternal condition at the bottom. So let's elaborate each of them. Now see here, okay, this is the different recording in the partograph. First is begin plotting at the 0 hour on the partogram. 0 hour means at the time of admission. This is called 0 hour. At the time of admission and at the time of examination. To be very precise, I should say at the time of examination is the 0 hour. The first time when she is admitted, when you examine, what finding you get, that is called 0 hour. Okay. Then second is all entries made in relation to time when the observations are made. We have to, plot according to the time now. See this. These are the pulse and blood pressure which is taken. So we have to plot it. And after some time, we have to take it again and we have to plot. And then we have to draw a graph. That is the way. The third step, notes should be legible, dated and timed. Legible, dated and timed. The proper time has to be mentioned. See this, the time of admission is mentioned, clearly mentioned here. The date is clearly mentioned. And how many hours the membrane has ruptured is clearly mentioned. And enter the outcome of the delivery at the end. So see there, single vaginal delivery, SVD, single vaginal delivery at 14:20 time. There is a live female infant with a weight of 2.85 kg. So I'm sure every student can see this. So this is the outcome of the delivery. Single baby is delivered at this time. She is live, female baby, and this is the good weight. So these are some of the steps of the partogram recording. Now let's move on. These are the different information from the mother when the mother is admitted, and during that time we need to enter that. What is the name? What is the age? What is the gravida and para? What is the gestational period? How many weeks of gestation? What is the date and time of admission? What is the time of rupture of membrane? Is it already 18 hour or 24 hour or even more than that? Or is it just 1 hour or 2 hour? Now, what is the danger if the rupture of the membrane is already 18 hour before? Yes, what is the danger of that? Anyone?
So maybe a fetal distress because the uterus
Prolonged labor. Prolonged labor, sir.
Affect the baby.
Okay. Now see this is a bit of a difficult question probably, so please pay attention. That amniotic membrane is preventing the infection going up towards the baby. That amniotic membrane is preventing the ascending infection which is going into the uterine cavity. So if it is rupturing much longer than the exact delivery time, already 18 hour, already 24 hour is there, and till that time the baby has not come out, so that baby has a high risk of getting infection. Okay, this is known as premature rupture of membrane, and it is associated with fetal infection as well as infection of uterine cavity as well. That's why we need to exactly ask when is the membrane ruptured. If possible, okay, mention some of the important antenatal history also. Now The another part is the fetal information. Now, please pay attention here. The fetal heart rate is the first thing. And every student know how we check the fetal heart rate in the hospital, in the delivery room, in the labor room. How we count fetal heart rate? Yes, how we count it?
By fetoscope,
Fetoscope,
Doppler.
Doppler, and by
Doppler, sir.
Healed and
stethoscope.
Doppler.
Exactly.
And
Exactly. I agree with all the answers. The best is a fetoscope, which is easily available there. Fetoscope, okay. It's quite easy. Another is a Doppler. Doppler is also available. Handheld Doppler, we say. Another is called cardiotocography. That is also a bit of advanced type of thing, which may be available. And if nothing is there, you can use your own stethoscope. Your own stethoscope, because you are a doctor there, okay. You have a stethoscope all the time. Sometimes that stethoscope is also used to hear the fetal heart rate, but fetoscope is the most commonly used. Now, what is the range of normal fetal heart rate? What is the range? Yes,
120 to 180.
120.
120 to 160.
excellent,
120
excellent,
to 160.
very good. 120 to 160 beat per minute. Okay, you need to answer like this: 120 to 160 beat per minute. This is the normal fetal heart rate. Now, if you find fetal heart rate more than 180, okay, more than 180 in the upper side and less than 100 in the lower side, this is known as fetal distress. So more than 180 and less than 100 is definitely abnormal. Now, from 120 to 100, still there is a range, remember that. So you should be alerted now. You should be alerted. You should be fast acting if that is happening. But still, the baby is surviving there. But less than 100, anything can happen to the baby. We may lose the baby already. So this is a very, very important point. And more than 180, the same type of things. Membrane and amniotic fluid. Now, what the membrane is intact or it is already ruptured. We can find that by per vaginal examination. And if amniotic fluid is leaking, what is the color? So many times I've explained this. It has to be the normal color. But if it is meconium stained amniotic fluid, that also signify a fetus is having distress or fetus is having hypoxia. So that is never normal. Okay. Now there are two types of rupture of the membrane. One is spontaneous rupture of the membrane that can happen on its own automatically. Second is called artificial rupture of membrane, which the doctor is doing when the lady is admitted. Till that time, if membrane is not ruptured, we definitely want to rupture it if labor pains are already started. Now there are two advantages of artificial rupture of membrane. Please pay attention. The first advantage is it will increase the progress of the labor. The progress of the labor is increased now after rupture of the membrane. And second, you can see what is the color of the fluid. If it is normal, you are relieved. If it is meconium stained, you have to probably hurry up. As soon as possible, the baby should be taken outside. The third important point is a molding. Okay, so molding is a overlapping of the fetal skull. So we have to judge that as well. So these are the fetal information. Let's move on. Now, when you are entering the fetal information, see this, some of the points here now, a bit of practical information for you because you are going to do this, quite sooner. Safe and reliable way of knowing fetus is well is detecting the fetal heart rate. If the fetal heart rate is within normal range, we are quite assured that baby is fine. Listen the fetal heart rate after each contraction for 1 minute. Complete 1 minute. Do not take for 10 to 15 seconds and multiply by 4 or 6. It is not like that. Okay, you have to completely hear it for full 1 minute. And then record it half hourly, Okay, each square is half hour. So see that there's each square there. These are the individual square. So each square are half an hour duration. So every half an hour you need to record it and plot it here. This is how the plotting look like. So all of you, please pay attention here. Is this fetal heart rate normal? What is shown in this graph? See this?
No, sir, not complete.
Abnormal.
Now,
Normal, sir.
okay. Now both answers I can agree. You know, look at, because in the beginning, see this, when you have started to trace it, it is touching 100, right? It is touching 100. So we are a bit alerted by this. We want to find out what is happening. But again, after some time, when you have retaken it, then it has come back to the normal. So we still believe this baby is fine. Now see this, the upper range is 150, the lower range is 100. It has not crossed 100. So though you are alerted because it has touched 100, but still the most of the tracings are within normal range. So I am not too concerned here. The second is, please mute yourself. The second important point is the character of amniotic fluid. So many times we talk about this. Every student know that by now, but there are certain practical points or practical information I have to provide for you. See here, if the membrane is intact, record as I. I means intact. Okay, this I is written here. If membrane is ruptured and liquor color is recorded as C. Okay, this is clear. Meconium stained liquor M, and liquor absent record as A. Sometimes the amniotic fluid is already drained, you know, there is no more left. So it is A, absent. Meconium stain is M, which looks green in color, sometimes even golden yellow in color if the meconium has passed around 2 to 3 days ago. And clear amniotic fluid is recorded as C. And if membranes are not ruptured, we record it as I. Now look at this graph. It is written C, 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 isn't it? Every time when they have examined, it is C. C means clear amniotic fluid. So this is a good thing. We are not too concerned about this. Now, all of you, please pay attention on this slide. You know, take a bit of time, please. See that? What is happening to the fetal heart rate? See this? So what is happening to the fetal heart rate here?
Fetal heart rate is decreasing, sir. Decreasing.
Even from the ultimate 100, it is that, sir.
Very good. So from the 140, okay, the fetal heart rate is gradually coming down, and it has already crossed the lower limit of 100. It is still lesser than 100. Now this is a very worrisome point. Okay. Now, please focus on the amniotic fluid here. Till this time it is C, means the color of the amniotic fluid is clear. Now after this B, okay, is a blood stained. Okay, a bit of rupture can happen, a blood stained, no problem. But here is M. What is the meaning of M? What is the meaning of M? See this?
Meconium.
Meconium passed.
Exactly. The baby has passed the meconium, but baby is not yet delivered. And now just correlate what is happening to the fetal heart rate and what is happening to the amniotic fluid liquor. See this. This baby is hypoxic. That's why the baby is having bradycardia, and that's why the baby has passed meconium inside. These things are matching with each other. This is such an important, you know, a concept here. Okay. And one more, look at the molding. In the beginning, 1+ molding, they're just touching with each other. Slight overlap, but 3+ means too much overlap, means too much molding. That also signify there is obstructed labor. the pelvic cavity is too narrow, so the baby is having obstruction to come down. Probably because of this, the baby is having hypoxia, which is showing by the fetal bradycardia, and the same baby has pars meconium inside the uterus. So everything is matching with each other. So this is a very, very important type of graph. This is the importance of partograph. See this? If a consultant is not there and you are taking care of that, pregnant lady, and she came after some time, just by one look, she can find out what's going on here. And this is a picture which is showing the dilated cervix with bag of water. So till now, there is no rupture of the amniotic fluid or membrane. This is called bag of the water. So what we do if this type of presentation is there, we rupture it by our own with the forceps. We allow that amniotic fluid to be drained. Now see this, regarding the molding of fetal skull, let's revise. It provides information about the adequacy of the pelvis to accommodate the fetal head. This is known as engagement. One of us know that now. Engagement. Record the degree of molding. 0. Bones are separated. +1 or 1 plus, whatever you want to say. Bones touching but can be separated. 2 plus, bones overlapping now, and 3 plus, bones are overlapping severely. So 3 plus molding is not good. Okay, it signifies the pelvis cavity or pelvic inlet is narrow. Now, after we judge about the fetus, let's go to the progress of the labor. And progress of the labor is judged by knowing the cervical dilation. What is the descent of the presenting part, and what about the uterine contraction? Is it adequate? Is it enough? Okay, what about the intensity? What about the duration? What about the frequency? Everything is judged here. This is the progress of the labor. Now let me go a bit slowly because these are a bit of practical information here, and let's take a bit of time here. Regarding the dilation and descent, latent phase is 0 to 3 centimeter, and active phase is after that up to 10 centimeters. All of us are quite clear here. These are the 2 phases of the first stage of the labor. Now, dilation of the cervix is plotted as X and descent is plotted as O. Okay, X and O. So this is just a representation here. Now all of you please focus here. See this? Now we can see cross mark here. Okay, cross mark or X, you can say, whatever, cross marks, and this is a 0. See this? This is a 0. So this is called descent, the plotting of the descent of the head, and this is the plotting of the cervical dilation. Okay, you can clearly see here in the graph. The first vaginal examination is done on admission, is recorded. The first time we record it. Subsequent vaginal examination is done every 2 to 4 hourly, and you record it again. And from there, you know exactly what is the progress of the labor, what is the progress of dilation, and what is the progress of descent. Transfer from latent to active phase is known by this type of plotting. Now, how we know what is the transfer? When it crosses 3 centimeter, we know latent phase has converted into the active phase. Now, some other information here. Plot dilation as cross or X, and plot descent as O. At admission, the dilation is 2 centimeter and descent is 5. 2 hours after admission, dilation is still 2 and descent is 4. Okay, this is 4. You all know about this descent, It is very rough type of representation actually. Let me revise once again. At the level of ischial spine, we call that 0. This is all the station we are talking about. This is station. But above the ischial spine, if the presenting part is still there, according to the centimeter, how much centimeter above? We call it minus. Okay, -1, -2, -3, -4, or -5. And when it comes below the ischial spine, we add plus there, like +1, +2, +3, +4, and +5. Now, what is the conclusion of this? As the dilation is only 2 centimeter, therefore the lever progress is in the latent phase. And descent is happening, from 5, it has come down to 4. This is in the latent phase. Okay, let's move on. See this? This is descent, and here is the dilation. X marks is for dilation, and this O is for the descent. So it is descending down. We are quite happy. But what about the dilation? We are not that happy. But remember, you are in the latent phase. It takes a long time to reach the 3 centimeter. So probably we don't need to do anything. Just continue the same management, whatever you are doing, because this is the latent phase. Now, all of you, before we go for another break, let's focus here. Lever progress recording in active phase now. So we all know this symbol, okay? Dilation and descent. This is the latent phase and this is the active phase. So see this. At the time of admission, the dilation was 2 centimeter. At 2 hours of the admission, it is 4 centimeter. And at 4 hours after the admission, it is 7 centimeter. And regarding the descent, okay, it is station 5, and suddenly it has come to the station 1. Okay, now probably this is minus. Okay, this is not the plus, probably still the minus station here, though it is written like this. Now, are you happy with this type of progress or not? Now look here very carefully and answer me. Are you happy with this progress? Of course, isn't it? There is a very good progress of the lever. From 2 centimeter it has gone. All of you, please mute yourself. So we're talking about the progress of the lever and what type of recording we do during the lever. So this is the lever progress recording in latent phase of the first stage. So this is the way how dilation is plotted, and this is the way how descent is plotted. So there is one example which is given here. The dilation at the time of admission is 2 centimeter and descent is 5 centimeter. After 2 hours, dilation is still 2 and descent has a bit of coming down. But this is in the latent phase, we are not that much worried. Okay, we are not that worried. See this? This is the way. So this is the way we plot it. And it has come down a little bit, but the dilation is a straight line, means it has not progressed. Now this is what we are talking. This is the lever progress recording in the active phase. Okay, this is a good type of dilation, and this is the descent. Descent is also quite nice. At 4 hours, it has already reached the 1 station. See this? This is the descent. This is the dilation. Okay. Now this is the plotting, isn't it? See this? Okay, it has gone very, very well, the dilation. Descent has also gone well now. Now, what about the plotting of cervical dilation? Every student know that by now. It has to be the per vaginal examination has to be done time and again, every 4 hours in the first stage of the lever, and then every 2 hours. If it crosses to right of the alert line, if it crosses to the right of alert line, this wants that labor may be prolonged. All of you, please focus here. Where is the alert line and where is the action line once again? Okay, do you know it already? See this? The first line, this type of line, the first line is the alert line. The second is the action line. Okay, so if it crosses to the right of the alert line, this is the right side, this is right side, here is the left side. So if it crosses right to the alert line, the labor is already prolonged and we need to take certain action. If it really crosses right of the action line, then it's already a bit worrisome for us. We definitely need to take certain action. This is the meaning. Now, when labor goes from latent to active phase, plotting of the dilation is immediately transferred from the latent phase area to the alert line. So this is the latent phase. This till here is the latent phase, and when this alert line starts, after this, the active phase of the labor start, and we need to plot graph accordingly. Just the practical things, you don't need to know that much at this phase actually. And when your senior would be working there, definitely they will teach you very nicely how to do all this type of plotting. Just the theoretical knowledge would be important now. Now, what about the uterine contraction? How we judge this uterine contraction, are strong or not? Are they enough or not? Observation is made every half hourly. Just put a hand on the intra-abdominal wall of that lady and judge for the uterine contraction. Assess the frequency and duration. Each square represents one contraction felt in 10 minutes. Now this is the square we're talking about. Please focus here, okay? This individual square. One square, okay, is one contraction felt in 10 minutes. Frequency is highlight the number of square. This is the meaning. Highlight means this one, the black color which is shown here. And duration, set the contraction in the square. So these are the different things. Purely practical knowledge. Less than 20 seconds, okay, mild. 20 to 40 seconds, moderate. And more than 40 seconds, strong. Now let's correlate this completely, black in color with this. This is a strong contraction which is shown in the graph. Strong contraction. Moderate contraction are shown like this, and mild contraction are shown like this. This is the way. So we may show you another graph, and in that another graph, despite of this black uniform color, if we show this type of color, you clearly know this is a mild type of contraction which may not be enough for the delivery or the progress of the labor. So we need to do what? If this type of contraction is there, according to the partogram, what you should do in your management now? Yes?
IV oxytocin.
IV oxytocin, sir, complete.
Exactly. Excellent. That means everybody is understanding the process. Very good. We have to give stimulation to the uterus, and that is done by IV oxytocin. Wonderful. Now, this is how we record the uterine contraction once again. Okay. These are the different, denotion or different symbol we say. Now, see this. See that. These are the mild contraction. These are the moderate contraction, and this is the very good contraction. Okay, excellent type of contraction. So these are the ones. This is how we denote it. Every 10 minutes we have to judge it. Okay, and this is one square is equivalent to, we take every 10-minute contraction. Now let's focus here. This is a normal labor progress. Now, why it is a normal labor progress? Just take a bit of time and judge yourself why it is normal. Look at this graph, okay, and try to find it out.
Sir, because of the cervix dilation, sir. Look at
Because of cervix dilation.
Very good. One is cervix dilation. It is progressing quite well. Then another point, yes.
Left side to the alert line, sir.
Very good.
It's
It is
normal.
still it is still left to the alert line. Excellent observation. So these are the two. These two observations are very nicely shown here.
And sir, also, sir, the rate of the cervix dilation is quite important here, sir.
Good. Third is the rate. The rate of the cervical dilation is very good. See this, okay? From 5 centimeter, it has gone to 8 and then the 10 centimeter. This is excellent. Okay, very good progress. Second point, it is left to the alert line, so we don't need to do anything. It is progressing quite well on its own. And these are the different things. Now, all of you, please focus on this graph. If you have understood well or not, okay, this graph will clearly tells us. See here, please. Now, why this lever is abnormal? Why this progress is abnormal? Now, what is the answer here?
Because the line is
Sir,
going
no proper cervix
right to
dilation.
the alert line.
And no
Okay.
proper dilation.
No proper dilation right of the cervix line.
Very
And
good. Good.
also reach
Also,
at the action line. Action line. We
also
have
heart
to
rate
take
is
action.
decreasing.
Good. Good. So see there. The
Heart
same,
rate is decreasing.
very good. So same points are coming again. So this is about again dilation and descent. Again dilation and descent only. Okay. See this. Let me use the pointer and explain. This is the symbol of dilation of the cervix, and this is the symbol for fetal descent. Now this is alert line. The alert line has already crossed, so you are already worried. And see this, it has even crossed the action line. Okay, so this definitely means prolonged labor. This is prolonged labor. Descent, fetal descent is not satisfactory at all. And then the cervical dilation is also not satisfactory in the active phase of the labor. Now, what should we do if this type of partogram is in front of us? What is management now? Yes? What should we do now?
First, we should
C-section.
Now, this is a very good question to ask the student, and your answer should be like this. You try to find out what is causing this prolonged labor. Now, let's go back. The prolonged labor topic, that's why I took that topic before this, so that the good concept is there for you. Three things. One is passenger, another is passage, and third is the power. What is wrong there? It is something wrong with the passenger, that is fetus. Is it something wrong with the pelvic cavity, that is passage? Or is it something wrong with the uterine contraction or the pushing, the maternal pushing? Okay, so all these things we need to judge first, and accordingly we need to act. If uterine contractions are not enough, stimulate that by IV oxytocin. But before that, make sure the pelvic cavity is adequate in size. If pelvic cavity itself is not adequate, straight away take that lady for cesarean section. You can't do any other thing. If the baby is quite big, if there is no engagement, take that for cesarean section. You also cannot do anything. Only thing you can do is uterine contraction. You can stimulate that. And if pelvic cavity is fine, if fetus size is good enough or smaller, which can pass through that pelvic cavity, after stimulating the uterine contraction, the labor can still occur normally. That's what we talked just now. Okay, so don't forget that. This partogram is just helping you to diagnose prolonged or abnormal labor right there in time, so that you can act like this. So this is the take-home message of this class. Now, all of you, please focus here. Okay, I'll give you a bit of time, so I'm sure you can clearly see on your screen. Just take a few seconds here. So what was this slide telling you? What about the contraction? Are you happy with the contraction here or not? Yes?
Yes, sir. Intensity increases, sir.
Very good. Yes, in the beginning they were weaker, but later on they become moderate to strong. So we are quite satisfied. It is not a lot of time which is spent there, because we are counting or recording this contraction every 10 minutes. Every 10 minutes. That's it. Okay. So we are quite satisfied with the progress of labor here according to the uterine contraction. Now we are coming toward the end of this topic. So at the end, we have to record what is the condition of the mother, and that is known by recording the vital sign. What is the blood pressure? What is the pulse rate? And what is the temperature? You can also record the respiratory rate, but there is no place for respiratory rate here. Okay, in Partograph there is no place for the respiratory rate, but still you can record it because that is one of the other vital sign. Urine analysis. Okay, what type of ketone is there? Is there any presence of albumin or any presence of glucose? Now let me ask this question once again. If ketone body is present in the urine, what does that signify? What does that mean?
Sir, ketoacidosis.
Diabetic
Diabetic
Good.
ketoacidosis, sir.
Good.
prolonged starvation, sir.
One is diabetic ketoacidosis and another is starvation.
Malnutrition.
Malnutrition or starvation. Excellent answer. Very good. Diabetic ketoacidosis or starvation or malnutrition. Especially starvation. Sometimes what happens that lady has not eaten for a longer time. She may have prolonged type of labor, and during that time nobody has given any food to her. So the ketone body may appear in the urine. So this is the important point here. And definitely in diabetic ketoacidosis, which develops in type 1 diabetes, ketone body is present. Now albumin. In which situation albumin is present in the urine? In which situation?
Sir, in this case, preeclampsia.
Good, Abbas. Good. Though I have not taken that class, but still you know it. There are so many conditions you can list here. So many. Okay, like any kidney disease, nephrotic syndrome, nephritic syndrome, glomerulonephritis, even in some cases of UTI, albumin may be present in the urine. But here, what we want to rule out is preeclamptic toxemia, okay, or preeclampsia we say, where there is hypertension during pregnancy with proteinuria. This is known as preeclamptic toxemia. Let me write that term here. Preeclampsia. Okay. Also known as preeclamptic toxemia. It's the same thing. It's a combination of PIH. PIH means pregnancy-induced hypertension. Okay, with proteinuria. Proteinuria means albuminuria. Proteinuria. So we want to rule out. That's why we are checking albumin in the urine. Glucose. Now 100% of the student can answer this. Glucose is present in the urine. What does that mean?
Gestational diabetes.
It's glucose
Gestational
diabetic.
Good. Excellent. It can be gestational diabetes or it can be chronic diabetes. Okay. Gestational diabetes or chronic diabetes. Now what is the difference? Gestational diabetes means the lady was not diabetic before. Because of the pregnancy, she is become diabetic. This is gestational one. Chronic, she has been diabetic from long time, and on top of that she become pregnant. In both these conditions, glucose may appear in the urine. Sometimes some healthy person also have glycosuria. If our threshold, okay, for the glucose is less, that is renal threshold for the glucose is less, glucose may appear in the urine. So we need to find that out, but that is a bit rare condition. Of a good answers you have already given. Check for the urine volume now, whether it is less. Okay, Sometimes in pre-eclamptic toxemia, there is damage to the kidney and urine volume is already less, which is known as oliguria. And what are the medication or drug given to that lady? One of the important drug we give is oxytocin. So we need to record it. How much oxytocin we have given, how many drops per minute. Okay. So, and any extra medicine you have given or not, like pethidine sometimes. How much IV fluid we have given. So all these things we have to record in the medications or drug given. Let's move on. Now all of you, please see here. Okay, this is the condition of the mother with some examples or some explanations, further explanation which is given here. Blood pressure is taken 4 hourly or more frequent if indicated. If indicated means if she is already a non-case of hypertension or she is already having pregnancy-induced hypertension, we have to take it more frequently than this, maybe 2 to 3 hourly. Pulse half hourly and temperature 4 hourly, and we need to record like this. Urine analysis is done by dipstick test. Acetone Niller plus, albumin Niller plus, and glucose Niller plus, we have to record it. Okay, we have to record exactly like this. So look at this graph now. Protein is negative, minus, nil. Okay, here also nil. Acetone is nil, here also nil. And this is the volume of the urine, 200 ml and 150 ml. Here is the temperature, 36.8, 37 degree, 37 degree. This is the recording of the blood pressure as well as the pulse. This is blood pressure. This arrow, this sign is for blood pressure, and this sign is for the pulse. This upper line is for the systolic blood pressure, and this lower small line is for the diastolic blood pressure. Okay, so I'm sure student can easily understand this, because blood pressure always have two readings, upper and the lower, systolic upper, diastolic lower, which you can clearly see here. This lady is having, the upper one is 110, the lower one is 70, and after 4 hours it is taken again, so it is still the same. So she is not hypertensive. This is not a case of hypertension. Now this slide is showing the partograph of the maternal condition. Look at this oxytocin here. Okay, unit per liter, and this is drops per minute. This is 10 units per liter. This is the unit of oxytocin, and this is drops. Okay, per minute. 15 drops, 30 drops, 30 drops, increase to 45, and continue that. Now here is the pulse. This is the recording of the pulse, this graph which I am showing to you, and is the recording of the blood pressure here. Now consistently the blood pressure is normal. Upper level is 110, lower level is 70. What about the pulse rate in this lady? What do you think? Is this normal or not? The pulse rate? Yes? Is this pulse normal or not? See this. This is 90, isn't it? 90. What is the normal pulse rate? What is normal pulse rate?
72 per minute.
It's
60 to 100, sir. Normal.
Okay. Any other answer?
It's normal.
40, sir, I think.
Same, sir. 60 to 100, sir.
Exactly. Always answer in a range. Okay. Always answer. Very good answer. 60 to 100 per minute. And this is a bit on the higher side, but it is not abnormal. It has not crossed 100. So we can consider it's still within normal range. And remember, pregnancy is a hypermetabolic condition. So there is slight amount of tachycardia present during pregnancy. It is slightly on the higher range, and we consider that as a normal. Now we have come towards the end of this topic. This is the analyzing of the progress of labor from the partogram. If progress is satisfactory, the plotting will remain on or to the left of the alert line. This is the take-home message from this class. Never forget this. If progress is satisfactory, the plotting will remain on or to the left of the alert line. And here is the alert line. So everything should be on the left side. We are quite satisfied or happy with the progress. Whereas, if the lever is not progressing normally, the plotting will be to the right of the alert line or in between the alert and the action line. And then we definitely need to do something because it is not satisfactory. Okay, so this is the last slide for today. So see this, these are the different lever patterns here. Normal lever is denoted like this broken line. Okay, this one. See this? Let me use the pointer. Maybe you cannot see properly. See this line. Okay, normal lever. Prolonged latent phase is by this one. Definitely, this is prolonged. Already the action line is here. It has already crossed it. Primary dysfunctional lever is shown by this red line. Dysfunctional lever. Probably the uterine contractions are not strong enough. And secondary arrest is shown by this purple line. Now, what is arrest? What is secondary arrest? Let me ask this question before I end this class. What is secondary arrest? Who can answer?
In second stage there is no next progression of the lever.
Good, very good. Though you need to mention what is the criteria there, okay, but the meaning is there. The lady has already entered into the second, active phase of the lever. She has already entered into the active phase of the first stage of the lever. Means the dilation is already more than 3 centimeters. After that, there is no progress of the dilation for another 2 hours. No progress at all. It is still 3 centimeters. Or if it has 4 centimeters, what you have got, after 2 hours also it is still 4 centimeters. This is called arrest. Okay, and this arrest is denoted by this line. Definitely, there is no progress at all. So these are some of the important information we get from the Partograph. So let me end this topic by repeating some of the very, very important point which you should never forget. The first thing is Partograph. What is this? Partograph is a graphical representation of every event what happens during labor. What is the fetal condition? What is the maternal condition? What is the progress of the labor? What is cervical dilation? What is the fetal descent? Everything is recorded, and that is called Partograph. Why we do that? Because we want to know whether this labor is progressing well or not. We want to know what is the condition of the fetus there. We want to know what is the condition of the mother. Just by one look, everything is known very well. This is Partograph. And what we discuss next is how to entry each of these things in that graph, and what we do at the end regarding the management. If that graph is crossing the alert line, we definitely need to do something because it is not satisfactory. If it is still on the left side of the alert line, we can wait because it is progressing quite nicely. Okay, nothing to hurry. And if it is crossing the action line already, we definitely have to do something right now. We cannot wait any longer. And that is usually cesarean section or some instrumental type of delivery like forceps or the vacuum, or we need to stimulate the contraction if it is happening there. Okay, with this let me stop here for today.